everyone. Thank you for joining me for ACEP's Capital Minute, a look at what's happening in Washington right now that's affecting emergency physicians and patients. I'm Laura Wooster. For the next 30 or so minutes, I'm going to give you an update of what's happening in our nation's capital, and then we'll open it up for questions. You can submit them at any time by using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live after my update. Today, we'll cover the ED violence bill reintroduction, COVID relief status, a promising meeting to discuss PPE concerns between ACEP, OSHA, and other national organizations, a regulatory update, and the latest on surprise billing implementation and what you can expect in the months ahead. This week started off with promising legislative developments on issues that ACEP has long supported. First, a bill to prevent ED violence and protect emergency physicians and others on the job was reintroduced by a bipartisan coalition in the House. Most of you have stories about physical assault or verbal abuse experienced on a shift. ACEP knows that too often these incidents go unreported or unaddressed, and that fearing for your safety should not just be part of the job. ACEP has worked closely for several years with Representative Joe Courtney of Connecticut to develop legislation that puts more workplace protections into law, and just yesterday, his bill was reintroduced. Through ACEP Advocacy on the Hill, stories with the media, and partnerships such as the No Silence on ED Violence campaign with the Emergency Nurses Association, we have made it a priority to let your voice be heard on this important issue. ACEP and ENA issued a joint statement applauding the bill that you can find on emergencyphysicians.org or on our public-facing Twitter account @EmergencyDocs. Among other provisions, this bipartisan bill has two major components. It would instruct the Occupational Safety and Health Administration, or OSHA, to issue an enforceable standard to protect frontline workers from predictable violence on the job. And it requires healthcare employers to have a plan in place to prevent violence from happening and respond when it does. These plans will ultimately be created to meet the specific needs of each facility, but may include de-escalation training, personal alarm devices, surveillance and monitoring systems, or other strategies. We look forward to helping see this important legislation signed into law. ACEP continues to advocate for more COVID relief for emergency physicians and is working to make sure that the funds actually reach the physician as intended. Financial support for COVID-related losses is still available. Now is the time to find out about your options if you have not already explored the federal resources available to you. The ACEP Regs and Eggs blog, written by Director of Regulatory Affairs Jeff Davis, offers a summary of federal support options that are still available. The most significant program that has been instituted to support healthcare providers during this difficult time is one we have discussed at length, the Provider Relief Fund, or PRF, a fund created by Congress last year to cover providers' lost revenues and increased expenses due to COVID-19. Over the last year, ACEP has written repeatedly to HHS outlining issues with how the department has chosen to allocate the funds, as well as expressing concerns about the PRF's confusing terms and conditions and reporting requirements. Despite multiple rounds of distributions, there's still a significant amount of funding left in the PRF that HHS needs to allocate. According to the HHS webpage that tracks spending from the fund, providers have received approximately $105 billion out of the $178 billion in available funding. So that means there's tens of billions of dollars still available. There are three important PRF updates for the last few months that you should probably know about. In December, HHS announced that it had completed its review of applications for the third round of general distributions from the PRF. In this third phase, HHS stated that it would distribute $24.5 billion to over 70,000 providers, thereby covering close to 90% of each applicant's reported lost revenues and net change in expenses. Then former President Trump signed the major COVID package into law, which among other provisions included an additional $3 billion for the PRF, bringing the total amount in the fund to $178 billion. The act also included other PRF stipulations of a clarification that a parent organization can transfer provider relief funds to a subsidiary, a description of how a provider may calculate lost revenues, and an important requirement that HHS must pay at least 85% of the remaining PRF funding beyond the phase 3 distribution based on lost revenues and increased expenses occurring in the third or fourth quarter of 2020 or the first quarter of 2021. HHS hasn't yet indicated how it plans on meeting this last requirement, but we expect that soon it will have to issue its plan for releasing the vast majority of the remaining PRF funds. And then in January of this year, HHS released revised reporting requirements for individuals or groups that received over $10,000 from the PRF already. The due date was initially this week for submitting required information related to the use of the funds, but it's been extended and the new deadline has not yet been announced. In the meantime, HHS has opened up a reporting portal and requests that all individuals or groups register. Registration takes around 20 minutes to complete. We encourage you to read through the details on ACEP's Regs and Eggs blog and the Provider Relief Fund website at hhs.gov. In other news about COVID relief, a bipartisan bill that ACEP supports to create a COVID commission is being introduced today in the House and Senate. Senators Bob Menendez and Susan Collins and Representatives Tom Malinowski and Mario Diaz-Balart introduced this bill to examine the United States preparedness for and response to the COVID-19 pandemic. The National Coronavirus Commission Act of 2021 is closely modeled on the 9/11 Commission and will examine inter and intra-governmental coordination, availability of PPE, vaccines, medical equipment, and other supplies, hospital and nursing home preparedness and response, and health and economic disparities, among other things. Given our strong feelings and firsthand experience with all of these topics, you can expect ACEP to watch this development closely and help inform these efforts wherever possible. Last week, ACEP was invited by OSHA to participate in a national meeting of healthcare industry leaders to solicit our recommendations on how best to strengthen COVID-19 workplace protections. This came about because of an executive order issued by President Biden in his first week in office stipulates that OSHA must consider whether any emergency temporary standards on COVID-19, including with respect to masks in the workplace, are necessary, and if such standards are determined to be necessary, issue them by March 15th of 2021. ACEP has been hearing directly from you about strong concerns regarding PPE, and we relayed those thoughts in the meeting directly to the regulatory body that can make important changes that impact your safety and ability to deliver quality care. ACEP took the opportunity to directly advocate to OSHA for emergency physicians' rights to be supplied effective PPE by their hospital, to wear their own PPE if they prefer, and to have access to peer support and mental health treatment without fear of professional reprisal. The regulatory environment continues to rapidly change, and many of the new policies will directly impact your practice. This week, Javier Becerra is in confirmation hearings for his nomination to be HHS Secretary. We were pleased to hear Senators Kane and Hassan ask him in these hearings about priorities near and dear to ACEP, including access to mental health support services for providers, eliminating the X waiver, and the surprise billing law's implementation. Thus far, it appears likely that he will be confirmed, making it the first time that a Latino will lead HHS at a time when health equity issues are front and center. Becerra does not have medical experience, although he has worked in depth on health policy. President Biden also nominated Chiquita Brooks LaShore to be the next CMS administrator. She was an Obama-era senior official at CMS, and prior to that, a Democratic staff member on the House Ways and Means Committee and managing director of a prominent DC health policy consulting firm. Elizabeth Fowler has also been tapped to run CMMI, the Center for Medicare and Medicaid Innovation. She's currently the Executive Vice President for Programs at the Commonwealth Fund. Before joining the fund, Dr. Fowler served as Vice President for Global Health Policy at Johnson & Johnson. She has extensive experience with healthcare delivery system and payment reform in the US and healthcare systems and reform in emerging markets overseas, and was previously a special assistant to President Obama on healthcare and economic policy at the National Economic Council, and she occupied key positions at HHS where she assisted with implementation of the ACA. As mentioned in our last Capital Minute, emergency physicians can now start getting reimbursed by Medicare for MAT services that you deliver in the emergency department. This is a policy that ACEP strongly advocated for and helped secure in the 2021 Physician Fee Schedule final rule. With this change, the Centers for Medicare and Medicaid Services finalized a proposal to create a new add-on code for MAT, G2213, that can be billed in addition to an ED evaluation and management code during an ED visit. The add-on code became effective on January 1st of this year, so you can already bill for this code. You may have questions, though, about how and when to bill the add-on code, and ACEP recently published a set of FAQs about it. Those are available on acep.org. And then lastly, CMS announced a special open enrollment period for the ACA's insurance marketplaces that started on Monday, February 15th, and will last through Saturday, May 15th. The opportunity to sign up for healthcare coverage will be available to consumers in the 36 states that use healthcare.gov. Furthermore, at least 13 states, plus the District of Columbia, which operate their own marketplace platforms, have decided to offer a similar opportunity to ensure access to insurance coverage during the COVID-19 pandemic. With the passage of the No Surprises Act at the end of last year, balance billing will be banned federally starting next January, and patients will be protected. But the devil's in the details, so ACEP is staying fully engaged as surprise billing discussions turn to implementation. The bill establishes a baseball-style independent dispute resolution process to help resolve any payment disputes between out-of-network providers and health plans. Next, we expect the U.S. Department of Health and Human Services, in conjunction with the Departments of Labor and Treasury, to issue a series of regulations throughout the year implementing the law. It's extremely important to ensure that federal agencies implement the various provisions of the law in line with Congress's intent and in a way that properly protects patients, while at the same time having health plans appropriately reimburse emergency physicians and other providers for services rendered. Congress provided federal agencies with some discretion in how to implement various policies of the law, such as elements of the independent dispute resolution process, and those details will be hashed out throughout the rulemaking process. The first regulation is set to come out in July. So what's ACEP doing? We've partnered with EDPMA to create an emergency medicine surprise billing implementation task force to develop comprehensive positions and align on consistent advocacy approaches to help make sure that this law is implemented in a way that continues to codify a fair dispute resolution process and levels the playing field for emergency physicians consistent with the legislative language while protecting patients. So that wraps up this week's Capitol Minute. As a reminder, this episode and all others are always available at acep.org/Capitol Minute. Now I'll be happy to take your questions. Remember, you can submit them using the Q&A feature of Zoom on the bottom of your screen. Here's a question. The protections outlined in the ED violence bill are promising. How likely is corresponding Senate activity? I do think that we have a good chance of getting the Senate to follow. I think this is an issue that there's wide recognition it's a problem, but we do want to see it introduced in the Senate, and we're working hard to get that to happen. And then hopefully we can even get it passed into law. This was reintroduced after we got it introduced in the last Congress. So we're happy just to have it on the books already this early in the new Congress. And we hope to see that play out pretty quickly. Let's see if there's another question. Is there something more we can be doing to help make sure that COVID relief reaches the physicians who need it? So, I mean, I would say look into your options. There is still money out there, like we said, in the Provider Relief Fund that groups can apply for. Unfortunately, despite heavy advocacy by us, there really isn't a way for relief to go directly to the individual physicians. So depending on your employment model, that makes it particularly hard to access. But there is PRF funding out there. And for those of you who are active in groups, especially smaller groups, there's also another round of the Paycheck Protection Program that you might be eligible for and is worth looking into for your organization. In the meantime, ACEP continues to advocate for additional COVID relief in other forms, not just through the Provider Relief Fund, to help out emergency physicians during this time. Let's see another question. Emergency physicians have long talked about preparedness. Is Congress seeing the need for more resources and planning with more urgency now? I think they are. The kind of formation, the potential formation of this commission through that bill that was just introduced, I think signals that they realize we need to do kind of a pretty thorough debrief on what's happened to date and where there were areas that we were more unprepared than others. That being said, memories in Congress are extremely short. So I think even with whatever findings this commission ends up happening, it'll still be a lot of work to ensure that Congress and the administration implement new measures to help keep us even more prepared. And I think some of the challenge will be that it'll be easier to get measures added to help prepare us better for a future pandemic that looks really similar to COVID. Unfortunately, I think it's going to be harder to get additional measures in place that go more broadly than that. And I think moving forward, there's probably more of a chance of something else happening on a mass level that looks different from COVID than there is of another very similar pandemic, right? So I think in a way, having this as an example is really helpful to get measures in place for something that looks exactly like this, but it might actually make it a little more challenging to get other types of preparedness in place, because I think people have to stretch their imaginations a bit and try to realize that it's not always going to look like this, and we might need different types of preparedness, and Congress still needs to enact measures like that as well. Right. So another question is, how does a commission style effort avoid the appearance of partisanship? There's a few ways to do that. I mean, the commission itself is bipartisan, right? So the bill that was introduced to create it is fully bipartisan. There were lead co-sponsors from each side of the aisle in the House and the Senate. And then the structure of the commission, I don't have the exact structure with me right at hand, but the structure is to usually what they do is they have key folks in each, like leadership in Congress or from certain committees. They each get to appoint one person per category. So there may be a category of state level officials. A Republican on the commission a Republican in Congress who is involved in this bill will be able to pick, let's say, a Republican, ideally from their perspective, state official. And then a Democrat who is involved with this bill or is in congressional leadership will be able to pick probably what would be a Democratic state official. So they'll be able to do that kind of one for one all throughout the different categories of people that will represent or make up the commission. And so that keeps it very bipartisan. That being said, I think we've seen that there are aspects of COVID and the response to it that are pretty quick to become partisan or be painted as partisan, even if they're not. So even with the commission, I think there still will be challenges in keeping it bipartisan and really keeping it to appear fully bipartisan. I think the commission itself will definitely be bipartisan. Actually, I have really no qualms about that if this bill were to pass into law. I think what would happen is it would be fully bipartisan. The work product will be fully bipartisan, but then messaging, once the work product was published, I think the messaging around it could become partisan with sort of each party kind of framing it in different ways for their own benefit. So there's another question, does the absence of a formally appointed HHS secretary or CMS administrator impact our priorities in the short term? It does a little bit in terms of right now. So there's still a lot of career officials in place who have been in HHS or CMS for a long time, and they're continuing their work, but any kind of bigger picture like work products that they create or produce does have to be signed off on by leadership. And right now there is no formal leadership. There's acting folks in place. So some of the bigger priorities cannot move ahead until a secretary or CMS administrator is in place to kind of sign off on them. So in the very short term, it's holding things up a little bit. We have meeting requests into the administration for some of our priority issues. And it's sort of a trade-off of, do we wait until those leaders are in place, or do we go ahead and have the meeting now, and then we can always follow up and have a second meeting with leadership once they're in place. So we do have to wait a little bit on some of that, but in the meantime, we're kind of charging ahead, and we're engaging with all the career staff who will have the ear of the leadership once they're approved in the Senate and put in place. What are we watching for with respect to surprise billing implementation? Do we anticipate that insurance companies could throw curveballs into surprise billing implementation? So there's quite a few things that we're keeping an eye on with respect to the implementation of surprise billing law. I would say things like requirements around what the insurer needs to pay up front and when they need to pay by is something we're keeping a very close eye on. And I'm sure the insurance companies will try to play that as much as possible wherever there's flexibility. The criteria that are being used in the independent dispute resolution process to decide which offer, whether from the insurer or the provider, is the prevailing one. Those are set in the surprise billing law, but they're not defined fully. And so how those are defined in the regulation and framed, I think can make a big difference. So we will be taking a very close look at that and trying to make sure that the insurers aren't able to kind of game the system using that. I think one of the other areas that we have concerns the insurance companies will game is in setting the median in-network rate that's going to be part of the IDR process, along with several other key factors. It's supposed to be pegged to what the rate was in January of 2019. So that is to prevent insurers having dropped their high cost contracts throughout 2019 when they knew surprise billing was being legislated in Congress and they were looking at median in networks, so that they can cheat on what that median in network was and drive it artificially lower. So that is part of the law, which we're happy to see. But it's not quite as clear as whether it's the insurer's own median in network and which of their products it's for, or is it for all the insurers in a geographic area. It seems to be, the law seems to point to it being for just the insurer, but there's still, I think, some latitude on which of their products. So we want to make sure, and what the geographic area itself is. So we want to make sure that's pretty carefully defined in a way that doesn't allow the insurers to kind of game the system and put you guys at a disadvantage. Kind of trying to think of what other areas might be right during the implementation process. I think those are the key areas. I talked about the IDR factors already. So regardless, we're keeping an eye on all of that. I think the other thing we're looking at is experiences at the state level, and trying to avoid anything that happened in implementation of state surprise billing or balance billing laws that ended up hurting us, and making sure that that doesn't happen again. For example, I know in Florida, I believe the way the balance billing law was written, the IDR process seemed fairly favorable from a emergency physician perspective, but then the insurers were able to kind of work their way into the regulatory process and the implementation side and turn what was thought to be somewhat favorable into a system that really isn't workable for the most part for emergency physicians. So we will be talking with a lot of our state counterparts to make sure that we avoid any of those same landmines. All right, we have time for one last question. ED violence is pervasive. What's the best way to share our story on this or other advocacy topics like physician mental health? So stories, like kind of real world stories on these types of issues are a huge help to our advocacy. So we definitely want to hear more from you about them. If you have a personal story of encountering violence against you or other staff in your emergency department, definitely share that with us. Same thing with physician mental health. We've talked a lot about our work on the Lorna Breen on the Dr. Lorna Breen Provider Protection Act, on getting emergency physicians and other frontline providers access to mental health services. And so it would be very helpful to have additional stories from folks like you on if you ever, if you're comfortable sharing these stories, if you ever avoided seeking peer support or mental health treatment because you were worried about professional recriminations, whether through state licensure or hospital credentialing, or if you know a colleague that happened to and are comfortable sharing on their behalf, obviously keeping everybody's identity anonymous, that would also be helpful. So definitely let us know, and you can share these stories with us. Just email us at pr@acep.org. If you'd rather not put the story in the email itself, just shoot us an email and we can get on the phone with you and talk that way, if that's easier for you, or if you're more comfortable. But yeah, we're compiling anecdotes from our physicians for media, for our social media channels, for conversations with the Hill, and with regulators and other activities. So the easiest way you can see how these stories are kind of helping us is you can visit emergencyphysicians.org or our public facing Twitter account, which is @emergencydocs. And you'll see some of the media coverage we've been able to get to on issues important to emergency physicians that help advance our advocacy causes. So that's it. Thank you everyone for joining us, and we'll be back in 2 weeks. See you soon.